Hi and welcome back to another video of Medic Notes. This video is on pancreatic cancer. Pancreatic cancer refers to the carcinoma arising from the pancreatic duct cells, pancreatic ductal carcinoma, and is the fourth leading cause of cancer deaths in the United States. The 5-year survival rate in the United States ranges from 5% to 15%. The overall survival rate is only 6%. Surgical resection is the only current option for a cure, but only 20% of pancreatic cancer is surgically resectable at the time of diagnosis. The risk factors of pancreas cancer are smoking. 20% of pancreatic cancers are caused by smoking. Age older than 55 years old, diabetes, obesity, chronic pancreatitis, cirrhosis of the liver, Helicobacter pylori infection, work exposure to chemicals in the dry cleaning and metalworking industry. Males more than females. African Americans more than whites. And family history. 10% have a genetic cause such as genetic mutations or association with syndromes such as Lynch syndrome, Peutz-Jeghers syndrome, von Hippel-Lindau syndrome, and MEN1. Possible risk factors include heavy alcohol consumption, coffee consumption, physical inactivity, high red meat consumption, and 2 or more soft drinks per day. For its types, more than 90% of adenocarcinomas of the pancreas are duct cell adenocarcinomas, with other types being cystadenocarcinoma and acinar cell carcinoma. 2/3 arise in the pancreatic head, 1/3 arise in the rest, which are the body and tail of the pancreas. Tumor markers associated with pancreatic cancer include CEA and CA19-9. Patients with adenocarcinoma of the pancreas typically present with painless jaundice, usually due to obstruction of the common bile duct from the pancreatic head tumor. Weight loss occurs in about 90% of patients. Abdominal pain occurs in about 75% of patients. Patients can have weakness, pruritus from bile salts in the skin, anorexia, palpable, non-tender, distended gallbladder, alcoholic stools, and dark urine. Sometimes, patients may present with recurrent deep vein thrombosis due to hypercoagulability. Patients can also present with recent onset diabetes. Lab findings will include elevation in liver function tests, direct and total bilirubin levels, elevated amylase and lipase, and elevated pancreatic tumor markers. For investigations, if adenocarcinoma of the pancreas is suspected, multi-detector computed tomography, MDCT, is the best imaging modality to diagnose and evaluate the extent of disease, including peravascular extension and distant metastasis. PET-CT scan can be useful in detecting distant metastatic disease. Abdominal MRI or MRCP with IV contrast is as good in the preoperative evaluation of pancreatic cancer and the assessment of vascular invasion. Ultrasound is of limited value in pancreatic imaging. Often, the pancreas will be poorly visualized sonographically secondary to bowel gas. Ultrasound can detect the secondary biliary ductal dilatation associated with pancreatic head cancer, but it is not helpful in visualizing the pancreatic mass itself. ERCP with endoscopic ultrasound can be performed, and fine needle aspiration biopsies can be done of suspicious lesions for the pathologic specimen. Endoscopic ultrasound, a test performed by gastroenterologists, can delineate the pancreatic mass, and can be used to biopsy the mass under ultrasound guidance. For staging of pancreas cancer. Stage 1, tumor is located in the pancreas and does not extend elsewhere. Stage 2, tumor infiltrates bile duct and other near structures. However, lymph nodes are negative. Stage 3, any positive lymph nodes. Stage 4A, metastasis into nearby organs such as stomach, liver, diaphragm, and adrenals. And Stage 4B, tumor infiltrates distant organs. Inoperability is signified on imaging by superior mesenteric artery encasement, liver metastasis, peritoneal implants, distal lymph node metastasis, and distant metastasis. Treatment depends on whether the tumor is resectable or non-resectable. This is determined based on vascular involvement and any evidence of distant mets. There are some indicators of unresectability. For lesions involving pancreatic head and uncinate process, they are unresectable if there is greater than 180 degrees involvement of the SMA and celiac axis. Presence of solid tumor contact with the first jejunal SMA branch. SMV or portal vein involvement that is not amenable for reconstruction. And evidence of contact with the most proximal draining jejunal branch into the SMV. Whereas for pancreatic body and tail lesions, they are unresectable if they are greater than 180 degrees involvement of SMA and or celiac axis. Aortic involvement, SMV or portal vein involvement that is not amenable for reconstruction. Borderline pancreatic tumors include tumors with short segment occlusion of the SMV or SMV portal vein confluence or hepatic artery. If the pancreatic adenocarcinoma is considered locally advanced, then by definition, it is unresectable. Neoadjuvant treatment with chemotherapy or radiation is typically preferred in this situation. If the adenocarcinoma of the pancreas is located in the head of the pancreas, then the Whipple procedure is the procedure of choice. If the tumor is in the body or tail of the pancreas, the distal resection is needed. Postoperatively, patients may receive chemotherapy with 5-FU, gemcitabine, and radiotherapy. If the hepatic artery is involved in the tumor, then the tumor is considered to be unresectable. However, if the superior mesenteric vein is involved in the tumor, then resection and vascular reconstruction. The same is true for portal vein involvement. It can be resected and reconstructed with a graft. For prognosis, the prognosis for pancreatic adenocarcinoma remains poor despite advances in cancer therapy. The 5-year survival rate is approximately 20%. Prognosis after 1 year of diagnosis is dismal, with 90% of patients dying at 1 year despite surgery. However, palliative surgery can be of benefit. Postoperative complications of pancreatic surgery include pancreatic fistulas, delayed gastric emptying, anastomotic leaks, bleeding, and infection. That's all for this video. Thank you.